Hi, my name is Dr. Vincent Cassiano. I'm board certified in family medicine and pain management. I'm going to give you a small talk about integrative pain management. This chart here is a chart that was created by the Army for a program called Move to Health. And it was an excellent program. And what it did was try to address patient concerns or patient medical conditions from a holistic standpoint. And whether it be for diabetes, heart disease, chronic pain, whatever medical condition you would have that has some chronicity to it, these are all the different regions of your life where likely there's room for improvement to help take care of the patient in a more holistic fashion. I've taken care of a lot of pain patients, both in a primary care realm as well as the interventional pain management realm. And this is probably one of the best paradigms I've seen for comprehensive, multimodal patient care. And so that's why you'll see this kind of pop up multiple times throughout this presentation. So something to keep in mind when we talk about integrative pain management. Integrative really means multimodal approach to taking care of patients. And now when you think about the multimodal approach, it largely breaks down into two categories. It's either passive management, which is what is done to you, or active management, which is what you do for you. And when you first come to a provider and your medical condition is poorly controlled, typically what you'll get is a very passive management heavy treatment plan. And most physicians are trained in this manner, that you have a problem, you seek help, we provide you with medications or some kind of intervention to try to handle your problem, which most times works out okay. But for regular medical conditions such as hypertension or diabetes, as well as chronic pain, where they're just not responding well, and it's probably because there's not enough multimodal approach to care for the patient. And so the examples of passive management for patients with chronic pain, things like spinal adjustments that you may get from either an osteopathic physician or a chiropractor, trigger point injections, dry needling, joint injections, epidurals, medication management, and acupuncture. These are all things that are done to you. So if you were to have really, really good response with any of these interventions and then you take them away from you, then likelihood is your symptoms would come back very quickly. So if you have, let's say, knee osteoarthritis that's really well controlled with corticosteroid injections into the knee, and then we stopped it doing those, your pain would come back and there would be really no significant change to your symptom control. Active management tends to give you a longer lasting relief because it's something you can take with you. It's something that when you're having a bad day, you can do something different for you instead of having to seek care from a doctor or other care provider. So examples of this are exercise, activity modifications, so changing your ergonomics, wearing protective equipment like knee braces, back braces, things like that. Getting good restful sleep, meditation, eating right, losing weight, which we've discussed in other lectures, how losing weight can potentially decrease full body pain. Physical therapy and behavioral therapy. And these are all things that you can do for yourself that will likely give you a longer lasting relief. These are three cycles that we've talked about in previous lectures. This is the sleep pain cycle, the kinesiophobia cycle, and the mood pain cycle. We've talked about how when you get deep, restful sleep, you are able to reset essentially your pain thermostat. It's your pain threshold, like how much discomfort one needs to be put in to experience pain. And this resets when you have deep, restful sleep. But what tends to happen for folks who have poor sleep at baseline, or if their pain is preventing them from sleeping, is that their pain worsens their quality of sleep, which then leads to insomnia, which then worsens their pain control. and it goes on and on. And as the pain gets worse, the sleep gets worse, which makes the pain worse. The kinesiophobia cycle is a fear of movement, kinesiophobia. And what tends to happen is you have pain, which makes you avoid activities such as exercise for fear of injuring yourself during those activities. But when you stop doing those activities, you become more immobile, more inflexible and weak, which worsens your pain, which makes you more scared to do the activity. And then one day you'll get fed up and decide to do the activity, and because you've deconditioned over time, you will actually injure yourself during doing the activity, which will only reinforce that you were right in the first place and should avoid the activity. And doing this over time only makes you more deconditioned and less functional. We also talked about the mood pain cycle. There's a process in your brain called descending inhibition, which means descending coming from top down or brain down. Inhibition is inhibiting pain. And so the portions of your brain responsible for doing this are actually dysfunctional when you have poorly controlled depression, anxiety, or PTSD. And so what tends to happen is you have an underlying condition, and maybe it started after you develop pain. Not everybody starts out with depression. And because you have poorly controlled mood symptoms, it tends to worsen as chronic pain takes more and more of the enjoyable parts of your life away. And doing that worsens your pain control, because the parts of your brain responsible to work as a dimmer switch for pain are impaired, which worsens your pain, which then worsens your mood, which then worsens your pain control, which then worsens your pain. And it goes on and on that way. And so again, we revisit the move to health paradigm, and we look at all the different ways that different parts of your life will contribute to how well you do with whatever medical condition, but in this case we're talking about chronic pain. You can see that sleep plays a role, your activity plays a role, your nutrition plays a role. So there are nutritional changes that can be done, such as eating less inflammatory foods, or potentially intermittent fasting, which is very, very anti-inflammatory, which may help chronic achiness from inflammatory processes or arthritis. Personal development is very big. So if you feel rudderless and aren't working towards a goal, or maybe you did work towards goals and you've achieved them, but now you're starting to lose the progress you've made because of chronic pain, that can negatively impact you. So potentially finding new goals to work towards. Your physical environment, so your surroundings. So if you have really, really bad knee and back pain, living in a home that has a ton of stairs may be really, really detrimental for you. Or if you're emotionally isolated, which is going to worsen your depression, which then worsens your pain control. The emotional aspect also plays a role, as we discussed with the mood pain cycle. Spiritual, and it's not necessarily religious, not everybody is religious, but feeling connected to a community is important. And family and social relationships are going to be important. So you can see how all of these have the potential of affecting your sleep, your activity, your mood, or your physical well-being. And so when we talk about making an integrative plan, we should be trying to do some homework in each of these sections. So understanding integrative pain management, again, integrative means that it's multimodal. So some of the passive modalities are listed kind of here, right? And so pain typically starts in the tissues. And so there's a little graphic of muscle, and then that pain anywhere in your body is transmitted through nerves. So if you were to take a pin and get stabbed in the thigh, you actually don't feel anything until the nerves carry that information to your spinal cord, which then carries it to your brain to be interpreted as pain. So different things we can do at the tissue level is you can take medications. If you have an inflammatory event for your muscles or your tissues, taking an oral anti-inflammatory, and there's just some examples here. Taking muscle relaxers if you have a muscle spasm. Muscle relaxers don't have great evidence for chronic use. They do have pretty good evidence for acute use, so somewhere in the neighborhood of 2 to 4 weeks of muscle spasms. Topical medications can be helpful. So these are medications that don't penetrate very deeply, but things like Lidoderm or Flector patches or capsaicin. And these medications can help, but typically would help for superficial pain such as muscles. Some interventions, so dry needling, trigger point injections, epidurals. There's all kinds of different interventions that can be done, but these act at the tissue sites, right? Including physical therapy and things like that. And so you have physical therapy, which, home physical therapy is more of an active modality. When you go to physical therapy, they're going to work with you with the exercises. So it'll start out passive and it'll work towards an active modality. That is what physical therapy does. Things like yoga and Tai Chi have level 1 evidence for being very effective for patients with chronic pain. Exercise, which we talked about, and activity modification. So all of these things, this is a mix of passive and active modalities, work at the tissue site. When you get to the spinal cord, really the things that work best there are going to be neuropathic medications, most commonly things like gabapentin or Lyrica or Cymbalta, which is an SNRI. And what these do is they just kind of dampen the pain signal. So if you want to think of your body as a car, this is the muffler. So it decreases the pain signal arising from your tissues and getting to your brain to be interpreted as pain. When it goes to the medications of the brain, things like Cymbalta again works here, some of your antidepressants work here, as well as opioids. So this doesn't fix anything, it just dampens the signal you're getting into your brain. Acupuncture can work here. This actually seems to, along with meditation, stimulate those parts of the brain responsible for descending inhibition. And this is where meditation and the diaphragmatic breathing that comes from yoga all kind of help out with stimulation of descending inhibition. Of course, behavioral health therapy is going to be very, very important, especially if you suffer from any concurrent mood disorders like depression, anxiety, or PTSD, as well as your sleep management. So this is a mix of both passive and active modalities, understanding where all they work to help take care of you. I would like to take an opportunity to talk about the problem with opioid use as your primary method of pain management. So we already talked about chronic pain is complex, it needs multimodal treatment, and medications are part of that. The issue people run into with opioids is the fact that they don't work well long term. And anybody who's been on opioids for a long time can think back to when they first started it and how it worked really well, and then over time it just doesn't work well, and you require larger doses to get the same kind of effect. So the way medications work is there's typically a cell that they're going after, and there's a receptor that is a certain shape, and the medication you take fills that receptor. The problem with opioids is it affects two different receptors on your nerve cell. It affects your mu receptor, which is largely responsible for a reduction in pain, and it affects your kappa receptors, which is largely responsible for your respiratory drive. So you have a opioid naive cell, you provide opioids, and those opioids are going to fill both your kappa and your mu receptors, which decreases your pain significantly, but it also partially decreases your respiratory drive. For the most part, when you first start out with opioids, it decreases pain significantly more than it decreases your respiratory drive. And that's why medications, when taken intermittently, are pretty safe. The problem arises a few weeks later, somewhere between 2 and probably 8 weeks, where your nerve cells start to reproduce additional mu receptors. And they also reproduce additional kappa receptors, but they're not able to reproduce kappa receptors as fast as they reproduce mu receptors. So somewhere in this neighborhood of 4 to 8 weeks, you're going to follow up with your physician who prescribed you the opioids, and you're going to let them know, like, hey, The medication was working great for me, but it's not really lasting as long as it was before, or I don't get as much pain relief as I did before. And what you may get, and what was very typical back in the early 2000s, is you may get a prescription for more tablets, to take either a larger milligrammage tablet or take maybe another tablet per day. And what that does then is the additional opiates will fill those mu receptors and you'll have a reduction in pain. But the problem is, because you weren't able to reproduce your kappa receptors fast enough, you take a larger hit to your respiratory drive. This cycle will repeat itself on and on for perpetuity. And so what will happen with patients who maybe have started opioid therapy 5, 10, 15 years ago is they will find themselves continuing to take their opiates at very high doses, which their kappa receptors aren't able to effectively reproduce as near as fast as their mu receptors. And this population of patients will have some pain relief from their opioids, but it won't be near as good as it used to be. And they will be at risk for accidental, potentially fatal overdose from their opiates, because their respiratory drive has been driven way, way down. There are several medications that are prescribed to treat some of the conditions that people suffer from who also suffer from chronic pain, such as benzodiazepines for anxiety. Certain muscle relaxers can decrease respiratory drive, and sometimes just drinking alcohol. And it does not necessarily need to be alcohol in excess. It can be really any amount of alcohol. You go to a barbecue and you have a beer, or you go to a wedding, have a glass of wine, and that mix of the alcohol with opioids, potentially with benzodiazepines co-prescribed, can lead to a potentially fatal overdose. So this is a chart I've created using data from a 2012 Pain Physician article, and taking the data out of that article and just putting it on a graphic so folks are able to understand. This is essentially how many tablets of very, very common medications that are prescribed as opiates it takes to increase your risk of death. And so the way this data was taken was it was all comers, I believe, in the state of Washington. And it was not necessarily people who abused their medication. It was just people who were taking it as prescribed. And this was the risk of death, not necessarily the risk of overdose. I believe for every one person who actually did die, there was about 8 additional people who overdosed but had a non-fatal overdose. So the way opioids are calculated is by using morphine as a standard. So every opioid that you're prescribed, they compare it against morphine for strength, so that way you have one unit that you can compare all of your different opioids to. And what you find is that if you were going to go with a safer regimen is considered less than 40 morphine equivalents per day. And this assumes that you're healthy, you don't have a co-prescription of a benzodiazepine, things like that. So this is all comers, and when we talk about safety, that's what we're talking about. Now you can see very quickly with something like MS-Contin or oxymorphone, you can very, very quickly hop over that 40 milligrams per day and increase your risk of sudden death by almost 4-fold. So between that 40 to 100 milligrams per day, your risk of spontaneous, accidental, fatal overdose is about 4 times. And the comparison is 4 times somebody prescribed at that 0 to 20 morphine milligram equivalents. And if you end up above 100, your risk of death, it goes up 9-fold. So significantly high. And again, these are for fatal overdoses. You can see the folks with fentanyl patches go up significantly higher. Fentanyl currently has been making its way through the news because of illicit use of fentanyl, but it is way, way more powerful than any of these other ones and does put you at significant increased risk. But many of these medications, if taken in excess, and excess can be a prescribed dose. It is very common for someone to be on 20 milligrams of oxycodone a couple times a day. And if you're there, you're going to be at increased risk of death, even if you take your medications as prescribed and are not abusing it. So nobody starts out at these super high dangerous doses, but if you continue to take your opioids as prescribed and you keep trying to take the medication to a level required for pain relief, you'll find that usually in a couple of years you are at a dangerous dose range. Fortunately, opioid weaning kind of works the same as titrating, but in reverse. So what you have is somebody who likely is in pain because their opioids stop working, or have very high doses of opioids, and you can actually get pain from opioids called opioid-induced hyperalgesia, which it gives you a horrible full body pain, typically experienced in patients who have opioid regimens above 90 morphine milligram equivalents. And so what you do for somebody who's interested in weaning, or in somebody who may have opioid-induced hyperalgesia, is you take away some of their opioids. Now, there's no agreed upon amount that you take off. I've seen it as aggressive as 20%. I've seen it as non-aggressive as 5%. As the most important thing is that you keep on kind of marching towards zero, or as low as you're able to go safely. And what happens is you have a transient worsening of pain, because now you have these mu receptors that are not covered by opioids, and so you have a transient worsening of pain. Typically it is transient, so about 1 to 2 weeks later, your body recognizes that it has more mu receptors unoccupied than it needs, and it'll actually get rid of the mu receptors. And what you'll notice is that your pain is no worse than it was in the first place, or if you're one of those patients with opioid-induced hyperalgesia, you might notice a significant improvement in your pain. And so frequently I talk with my patients and I ask them, well, what have you tried for medications? And they'll come back and they'll say, I've tried everything. And to which I say, like, I'm not sure you've tried everything. There's a lot of different medications, and not every medication works for a patient, but there are a lot of different classes of medications. And so what I recommend for folks is that we work our way through at least 1 or 2 medications in each of these categories to try to see if we can provide you with non-opioid options. So most important thing for longitudinal improvement in a patient with chronic pain is to make real goals. And so these should not be pain-related goals. I emphasize that. I can't tell you how important it is to not let pain control your life and own you. You know, if you're in a everyday 8 out of 10 pain, your goal shouldn't be to be at a 2 out of 10 pain. I challenge you to think of all the things you enjoyed in your life that pain has taken from you, whether it be hobbies or activities, sports, whatever it is that you enjoy that has been robbed from you because you've lived with chronic pain. And our goals should be incremental to get you back to enjoying those things that you haven't been able to enjoy. So if you really, really, really miss going for a jog, then my question to you is, how much do you jog now? And if you don't jog at all, then let's make goals to get you walking, and we maybe get you walk around the block. And once you get there, maybe we'll get you walk around the block twice. And then once you get there, maybe we have you go for a really short jog around the block. And we just incrementally get you back to where you were, or as close to it as we can, to get you back to enjoying life. And that's real goals. Your goals should not be to decrease your pain by 50% or something like that, because then you're allowing pain to continue to have a control over your life. So my homework to you is to find something from each category that you can improve, right? Whether it be activity or nutrition, personal development, fixing something about your surroundings to make it more conducive for pain, working on any emotional work you need or spiritual work you need, working to repair some of the family or social relationships you have, or something to improve your sleep. And there's a myriad of different resources available for each of these categories, both written, online, or going to your physician or a specialty provider who can help you with these things. So I'm sure you have questions for me. You can feel free to leave some questions in the comments. I periodically check, and I promise I will not get back to you as fast as you'll probably like. And I do not leave medical advice in the comments. I highly advise you cultivate a close relationship with your primary care provider or your pain physician to try to work on some of these things. All right, well, this is Dr. Cassiano. Be well.